Leila, can you hear me?
Yes, I can hear you.
Would you like to share your screen, Dr.
Sure.
Leila? Thank you. That's very kind.
Share, sorry. Can you see it, Alok?
Not at the moment, no.
Okay. I don't know what's happening. Oh my God.
Don't worry, take your time. There's no hurry.
Interesting. Can I try again?
Yeah, absolutely. I've made you co-host as well, just in case. Yep.
So it's share, right? I mean, I did that last time. Share.
Yep, you did. So it's
And
sharing
then
the screen.
it's asking me PDF or PowerPoint. I'll just choose the PowerPoint. Yeah.
Yeah. So if you can see the PowerPoint on the screen, you can choose it. You choose the PowerPoint. Yep.
Okay. Interesting. I don't know why it's not allowing me this time. This is my PowerPoint. Share. It's not letting me. Sorry.
So can you see multiple screens on your laptop or desktop?
I only opened the PowerPoint.
You've only opened the PowerPoint. Okay.
Yeah, but when I click share this time, asking me attach a copy instead. So I chose the PowerPoint. And welcome to Outlook. Next. Sorry, Alok, it's not happening.
Don't worry, it's okay, not a problem. What we might be able to do is, I'm back to work tomorrow. We can have a look at it and see how that works.
Unfortunately.
Don't worry, absolutely no problem. So the next person who I've got is Dr. Rana. Dr. Rana, would you like to share your screen?
Hi. Yes.
Amazing.
I just double check that this is the
correct one. No, it's not that one, sorry.
Not a problem.
Is it in a presenter
mode at the moment, or?
It's not in presenter mode. You'll have to click on presenter mode at the bottom, just there. Perfect. That's it. Now it's in presenter mode, so you're audible and visible.
Okay, thank you. So the background is it was the 38 weeks baby, birth weight 3.8 kilograms, was born by an emergency cesarean section in labor due to thick meconium and some decelerations on the CTG. There was a clinical and echo diagnosis of severe PPHN and meconium aspiration syndrome. This baby was on full support in high frequency nitric and inotropes as well. So I did the first ultrasound scan at around 10 hours of age. I used the GE machine E90, and we've got the probe of S12, which has a frequency between 12 and 9. So on that one, I think I used the frequency of 9 on this baby because it was a big baby. Just to start.
Very nice. Are you oscillated?
So at that point, the baby was on the oscillator. Sorry, I think I moved on one.
So the beautiful images. They're
Thank you.
beautiful. Yeah.
So the first image on the right side of the screen. So this is L1. You can see that the pleural line. You can see the pleural line. There is some sliding, but not very much sliding. I think that was just because the baby was on the oscillator. There is some thick pleural lines, and mainly is just a B profile there. I think I can see there is some possible as well consolidation right there, and also here at the bottom. I have to say that because the footprint of that probe is quite small and the baby is big, so I took few images of all areas, but I only chose one just to represent what that profile had shown. So I thought on the L1 it was mainly a B profile with suspected some consolidation there at the bottom. Here on L2, I can see that the pleural line is also sliding, but not very well sliding as it should be. And I think that is again because of the baby was on the oscillator. I can see some mainly B lines quite consolidated, but some A lines as well. So there was some variation in L2. So I would call that an AB profile.
Yep, I would agree.
Moving on to L3 and L4. L3 here, you can see that the pleural line is quite thick, and it's mainly just B lines, quite coalescent B lines. And here, I don't know if you can see it as well. It was more obvious on the machine, but there is some areas here of consolidation.
Absolutely.
Some air bronchogram there. Here on L4 as well, the pleural line as well sliding, but it's quite thick and irregular, and it's mainly B profile with quite coalescent B lines.
Very good. Very
Moving
nice.
on to
Beautiful.
the right lung. So on R1, the pleural line is also sliding, but it's not very well sliding. Mainly, well, it's an AB profile, so we can see a lot of B lines, but some A lines as well. I have to say I dropped a B mode in here, but I didn't put it here, but it did not show the barcode sign. So there was no pneumothorax in this area.
Yeah, very nice.
On R2 as well, the pleural line is quite thick and some minimal sliding. Mainly B lines, but some A lines here in the middle as well. So AB profile. So the anterior part of the right lung is slightly aerated.
Excellent.
R3 and R4. So here on R3, so we can see that there is some pleural line here, which is quite thick and irregular, but here the pleural line is quite broken, with an area of consolidation here. There is some air bronchogram, which I think there is a mix of static and dynamic air bronchogram. I think these areas here are mainly static, but I think there is some here which are dynamic.
I agree. I agree.
So that's why I think this area is more like consolidation rather than a collapsed area. On R4, the pleural line is quite thick and irregular, but it's mainly just a B profile here.
Very good.
Meconium aspiration.
Very nice.
On day 3, this baby deteriorated with increased oxygen requirements, and this is the X-ray. I've taken this X-ray with my phone, so there is some kind of reflection here. That is not
that's fine. That's fine. Yeah.
Yeah.
Let's go back to your images, Dr. Rana, because they're beautiful. And I mean, I just wanted to say to everybody that again, you do not need to have a hockey stick or a linear probe to actually be able to make diagnosis. And this is a very nice example of beautiful lung ultrasound. So we'll go right to the start because,
sorry.
That's all right. Not to worry. Take your time.
So this is back to L1, L2.
Yeah. So what I definitely say, like when you look at L1, you've definitely got like going in, and if I just think about the pleura, there is sliding. The reason there's sliding is because you've got B lines, coalescent, possibly compact B lines, I'd say big ones, which basically move, and they move with the oscillator. Sliding absolutely without a doubt. I'd agree the pleura looks a little bit on the thick side. It's irregular. Now, this is the challenge that we have with using the probe that is kind of either a sector or an S9, is that the pleura may appear slightly different. But actually, for me, this is beautiful. I would agree it's irregular. I do wonder whether you've got some subpleural consolidations there. And the problem with the deep consolidation that you see, it's a little bit tricky, because we're using the sector probe and you lose your pleural line. So it may be that it is a deep consolidation, or it may be artifact as well. And really what we'd like to see is origin. And what I'd say is that this is very common when you go to the left upper lobe. So what you might have to do, especially if you're using a probe that's either a sector probe, is move it or angulate it a little bit so that you can actually get that entire area. But these absolutely beautiful L1 image, and L2 for me is very well aerated. I would actually say, there's like if I move to the left of your screen, so left there. So again, whether there's a subpleural consolidation that you can see over there, just coming in, that dark area, but definitely well aerated lung over there. So we'll move on. So how many hours old was the baby at the stage?
She was about 10 hours of age at that point.
Okay. And just one question from my perspective. Did you give her surfactant? She
did get surfactant, yeah.
But again, so this is after the surfactant's been given.
Yeah.
So, I mean, here again, very nice, basically an AIS pattern in L3. An AIS and and sliding is visible. You have subpleural consolidations there just under the pleural line. Now, the challenge for us is if you don't have a history of meconium, making a diagnosis of RDS is also possible. But clinical correlation, absolutely key. You've clearly got meconium. And then in your next image, so let's go to your next image. Again, well aerated lungs. Now, can I just say this concept that you can see double lung points in meconium aspiration, you can see them in TTN, and you can see them in RDS. So here you've got double lung points. You've got a B profile. So if you look at R1, extreme left. So if you just, that's a B profile. Then just go to the other side, extreme right. That's also B profile. And then you've got an A profile in between. So this is a double lung point. And what I'd say is that I can, with the eye of faith, see some comet tails with the A profile. And there are these lines, these horizontal lines that go all the way down, that they diverge. These are called pseudo B lines or Z lines. They are B line mimics. They are not true B lines. So you must not get confused. They are classical B line mimics. And what you'll often find is that they don't quite take their origin all the way from the pleural line. You have some comets at the top in between where the lung is aerated. But these lines tend to kind of midway, they start diverging and they widen up. So they're actually B-line mimics. But this is a beautiful double lung point. And R2, very similar. Again, you have subpleural consolidations that are better visible in R2. Beautiful images. And then we'll go to the next image and let's see your consolidation. So now, when you look at R3, and I would completely agree with you. I think this is more consolidation than atelectasis. Now, some people may get confused because there's no pleural line visible. But for me, that's actually rib artifact because it goes all the way down. The darkness in the absence of the pleural line is because you've got, But actually, if you see, you can see pleural line just above with what is consolidation and then static air bronchograms. And with the eye of faith, I think if you magnify that area, I would agree there's probably a line that goes in and out. So again, this would be a consolidation for me, and worth putting Doppler on it just to see. But I mean, this then kind of, so you can see this in RDS as well, but with your history, I think I would agree this is very likely to be meconium aspiration. And you've got a very nice B profile in R4 with kind of, coalesced B lines. Any questions from anybody? So let's see what the chat says. So Naz, yes, it is post-surfactant. Dr. Hamad wanted to see the pseudo B lines or the B line mimics. If we just go back to your previous slide. So just in the middle there, yeah, just that straight line that comes down and diverges.
Yeah.
It doesn't go all the way to the top. It doesn't take its origin from the pleural line. It becomes apparent lower down. Whereas if you look at the other B lines, they take their origin all the way from the pleural margin. They are true B lines, but this is a B line mimic. And this must not be confused with a B line. And the reason for that is it does not extend all the way up to the pleura. So some people will sometimes label this as B lines. They're not true B lines because they do not originate from the pleura.
Mm-hmm.
Does that help, Dr. Hamad? Okay, that's really kind. Do you have any other cases?
Yeah, I just have, so on this baby, just 3 more videos.
Please,
so
please,
this baby
please.
deteriorated on day 3 with high oxygen requirements. And this is the chest x-ray which she had. So just bilateral, I don't know if that you can see that, just bilateral reticular opacities on both sides. So I did an ultrasound scan here. And I'll just show you what I saw on R3 because this is just to see what happened to that consolidated area here.
Yep.
But I've shown 3 clips of this area because it was such a large area R3 with a small footprint of the probe.
Yep.
So you can see here on the view on the clip on the right. So the pleura on the left of the screen is quite thick and irregular with lots of coalescent B lines. But right next to it, there is this area here which is consolidated with a broken pleural line and static and dynamic. I think this is a dynamic air bronchogram. And some fluid bronchogram here as well.
Very nice, beautiful. Yeah. So for everybody, sorry, I'm so sorry. Yeah. I apologize. I'm interrupting you because it always excites me to see a fluid bronchogram. So for everybody, because I haven't shown you fluid bronchograms, that is a fluid bronchogram that you see in dark. It's beautiful, and I would agree that's a consolidation. And then there's an absolutely beautiful image in R3, but I won't steal your thunder.
So this is the next part of R3 as well. You can see hepatization of of the right lung here is just basically all consolidated tissue. And I think that is a fluid bronchogram as well here right at the bottom.
Absolutely, absolutely. With some static bronchograms within that are expanding and kind of collapsing with inspiration, expiration. I mean, my worry at this particular point would be whether that could be a mnemonic consolidation and secondary infection. And again, because you've just lost your pleura, and this is what I would say to everybody, differentiating an atelectasis from a consolidation can be very difficult. Once you lose your pleura right up at the top margin, whether there's an element of atelectasis there as well. And the only reason I mentioned that is, so what else can you see there, Dr. Hamad? Sorry, Dr. Ali, I apologize. What do you think that is, that movement?
That's the pulsation.
Yeah, that's lung pulse.
Lung pulse. Yeah,
so
lung pulsation.
Again, very classical with mnemonic consolidation. You've got all 4 features. It's beautiful. What's your CRP?
Yeah. And just one more.
Please.
This is the last one, just to show you this area with shred sign, I thought. There is this basically consolidated area. I think that is a dynamic air bronchogram there, but some static as well, static bronchogram and quite broken pleural line. So a big consolidation in this area here.
Yep, it's it should, I would want it to be a little bit more irregular for it to be a fractal or a shred sign. Could it be a large atelectasis, an area of atelectasis, just subpleural, or it could possibly be because it's very irregular to the right margin. I would agree.
Yeah,
So
I just saw that there were some areas here of
fluid bronchogram.
dynamic bronchogram. So that's why I thought probably it's not atelectasis, it's a consolidated area there.
Fair point. Fair point. Actually, you're right. That's not a fluid bronchogram. That is a dynamic bronchogram going in and out. It looks a little bit dark below. So you're right, actually. That would go in favor. I would have loved to have had a Doppler on it.
Yeah.
It would. You've done a Doppler?
I didn't. No, I did it before before you gave that lecture on consolidation. So I did not do the Doppler on this one.
Lovely. Beautiful images. I
Thank
have
you.
no critique. Yep. The CRP was high.
That's the last slide.
Sure. Okay, that's amazing. That's a beautiful case.
Thank
Look,
you.
I think I figured out my screen, if that's okay. Can I?
Yeah, sure. You can go for it, Dr. Leila.
Okay.
Thank you, Dr. Alia. I'm so grateful.
And
Beautiful
I've been
images.
admitting everybody, by the way. Okay, share. Can you see my screen now?
Yes, we can. Thank you so much, Dr. Leila. That's beautiful.
Okay, so I'm just going to go to.
So should we, yeah, beautiful.
So GE machine, we are using frequency linear probe of 9 to 11, and the depth of 4. This is a 47 hours old. Actually, we did the scan, me and Ghalia together. 1037 weaker, 2.47 kilogram, admitted to respiratory distress. And the baby was in DUPAP and was still needing 40% oxygen. And the team was asking themselves, this is pneumonia, congenital pneumonia, or TTN or RDS, and should we get surfactant at this time or not? That was the question. So we offered to do ultrasound. We did ultrasound of the chest. And this is, baby was prone position. So we started from the back, R5. And what we see here, sliding pleura, more than 4 ribs and more than 3 intercostal spaces. There is a thick area here. It could be subpleural consolidation and P profile mainly.
Beautiful image, Dr. Leila. So can I just say that taking the back in a baby who is on CPAP, they often back arch. And can you see how there's complete continuity throughout? There's always thicker tissue on the back, but despite that, you've got excellent penetration up to 3 centimeters. Your gain settings are appropriate. I can see all the way down, and I would agree there's definitely what looks like a little bit of subpleural consolidation with a B profile sliding throughout. Beautiful image.
And are these A lines?
Yep, they are. They are.
Can we call it AB line, AB profile here?
I think if you call this a B profile with a little bit of variation, I would be happy with that. If you said it's a kind of an AB profile, that would be acceptable as well.
Okay. And of course, here we see some dynamic bronchograms in the area here.
I think there's subpleural consolidations. I would call them subpleural consolidation.
Okay.
Yeah.
Okay. So this is R6.
Very nice.
And here we see more kind of sliding pleura again, and one of my plays not working again.
That's okay. They're playing beautifully, Dr. Leila. Very nice images.
And you see, I could call here a double lung point because you see the A profile here, and B profile here.
I would agree.
Okay. So this is when the baby starts moving. We're struggling to get perpendicular, the probe. And again, we see here mostly pre-profile, but I don't see any subpleural consolidation here. We come into R4, P-profile again, and no subpleural consolidation, and now sliding.
The middle of R4, we'll just go back to R4, Dr. Leila. So just if you play it again. This is R1.
R1?
We go. So we had R4. We were going.
Yeah, sure. R4.
Yeah, just there. I just wonder whether you do have subpleural consolidation there, just especially in the middle of R4.
Okay.
Yeah, just
over here.
Yeah,
yes. Yeah, just there and to the left.
Okay. So this
Yeah.
one here.
Yeah.
And this one
Yes.
here.
Yes.
Okay.
Yeah. Just wonder whether you have. They look certainly thicker than 5 millimeters. You know, if I think about them.
I have the prelude. Okay. Okay. So I went back. I don't know why I'm going back to R4. Okay.
That's all right.
So this area here and this area here, you're saying, right?
Yeah.
Okay. Excellent. Okay. And then now R1, we move the baby. Thicken pleural now. I could see more subpleural consolidation.
Yep. Definitely see some pleural consolidation here. Yeah, and quite a thick pleura, I would agree.
R2 exactly the same, so I'm not going to waste time here.
No problem.
Okay, and then R2, and this is now we move into the left side, L1. Again, thicken with subpleural and B profile mostly. What do you think?
I would agree, and I think you're right here. It's a little bit tricky whether there are subpleural, but definitely a blurred pleural line, which is relatively regular, a B profile, complete compact B lines, possibly AIS. Yeah.
So look here, we try to reduce the depth, and then we try to reduce the frequency to see if we can get the whole B line to the end. But it wasn't easy. So still we have to black out in yeah.
I'm still able to interpret right up to 3 centimeters. So that looks more than acceptable to me. Yeah.
Okay, and now L2.
Well done. Picture. Well done. The heart, it's always challenging. Very similar picture. I'd agree.
Again, L2.
Just again, whether you've got some subpleural consolidations there, or whether that's because the probe is not entirely 90 degrees.
This one here.
Yeah. So.
Okay. So when we came, and that's what we thought. So we decided. When we were doing, the study, there was an area coming to us like this, and we were not sure if this is pneumothorax or pneumotestinum. So we put the MEM mode, and this was the picture we saw. So we thought, well, this is looked like a seashore. This is not a pneumothorax.
I think you've got diaphragm there.
I
think you've got diaphragm there. That's why you're getting the wavy appearance.
This is the diaphragm.
Yeah. No, that my feeling is the liver, and you have where your cursor is just the diaphragm.
I see.
And then
Okay.
But yeah, that would theoretically, if you went higher, you've got clear sliding. Absolutely no doubt about it. Yeah. Yep.
Now we are. I think this is L4.
Beautiful. Yeah.
And then L4 again. And just trying to practice what you taught us in the course. So we saw this area here we were worried about. So we did the horizontal image view, and then we did also the Doppler. But we don't see any increased flow in the Doppler.
No. But you definitely have subpleural consolidation, especially if you look at L5 in the middle. Yeah.
Oh, sorry.
Just below. No, just there. Play it again. So, yeah, if you play it again. So just in the middle, you can see that area of consolidation there. Yeah, there. Just come a little bit lower. Can you see how it moves up and down from the pleural line? So definitely you have subpleural consolidation there. Yeah.
Okay.
Beautiful. Yep. See that? Up and down it moves. Yeah. Very nice.
Okay. And this is, I think, L6, which is again the same thing. Mostly, I would go even IAS.
Yeah. Absolutely. Yep. AIS. No doubt about it.
Okay, so here we're trying to do the blob, the one you taught us in the last course. I don't know if we're getting this right or not. So I think
you've got liver there.
Okay.
That's all liver. Yeah.
That's all liver. So that's this is all the diaphragm here.
Yeah, and the question is whether you might have a little effusion there.
Fusion, exactly. Yeah.
That's the left side.
This is the left side. Yes.
Yeah,
the spleen. Sorry. Yeah.
Yeah. My apologies. You're right. This is the left side. So this is the spleen. You can see
Mm-hmm.
the diaphragm, and just below the diaphragm, there's an area of fluid. So just in the subcapsular space over
here.
But just above that, there's a small pocket, triangle space. So just whether you've got a very minimal pleural effusion as well.
Okay.
Which is best seen in that view. So yeah.
Okay. So blob in the right.
I just hope that's not pericardium actually. Can we just have a look at it again?
Sure.
Yeah. Because I just think that might be the heart and the pericardium and whether but it's very triangular. It's tricky to say. You've got rib above that, so that must be pleura. That must be pleura. Yeah. Yep. You're very low, Dr. Leila. You need to go a little bit higher for the PLAPS point. And it needs to be
higher.
Yeah.
And this is the right side. So this is diaphragm.
Yeah.
Right. And that would be the lungs here. And this is the liver.
Yeah. Very nice. Yeah. And it's, I mean, completely white lungs. There's no aeration there. So what did you think about your diagnosis?
So looking at the baby, clinically, we thought in the end, this could be just advanced TTN. I think Ghali did disagree, and she thinks it was RDS. We ended up not giving this baby surfactant, and he was fine by next day.
Okay. I mean, I suppose following the clinical course, we know that there's a spectrum where you can get a bit of both. And I think clinically, this is one of those cases which sometimes kind of hits in between. But from what you're describing clinically, you're probably right. It is probably TTN if it's resolved and you haven't had to do anything at all. And I mean, it just shows how challenging and confusing things can sometimes be. Serial ultrasounds here really help because if you kind of see the appearance of a lot of double lung points without treatment, then that is the convalescent phase of TTN, and the diagnosis then goes more in favor of TTN as opposed to RDS. And that's why it's really important that if the first scan is confusing, that you can do serial scans to try and make a diagnosis and differentiate the two.
And Alok, you would do that even if the baby was improving clinically?
No, you're right.
No.
I think if he's improving clinically, I wouldn't. Why should I handle him? But like if I just wanted to kind of think of confirming my diagnosis, and I did a subsequent scan for the purposes of kind of wanting to recognize, and I saw lots of double lung points come up with more of a, I would say, resolving kind of a pattern of, well, Dr. Liu says that if you see AIS with that pattern, then it favors TTN as opposed to RDS, which will have a much longer course. The subpleural consolidations would have disappeared, whereas an RDS still persist, especially if you haven't treated with surfactant. So, that's a good differentiating feature.
Okay.
You didn't have the, yeah, go for it. Yeah.
Thank you. It will be 8 here. So again, the same machine and the same depth and frequency. So this is a 4-year-old baby, preterm, 31 week and 1.8 kilogram, who had received steroid antenatally just for 2 hours before the delivery. Baby required a CPAP at 5 minutes and started getting more requirement for oxygen. And then finally, we put him in CPAP because he did very well initially. And then at 6 centimeters CPAP, he went down to 27. I was really curious because the baby was grunting a lot. So I said, let's do the scan and see what exactly we see. And thinking of the last talk about, and prediction for surfactant. So this is the first slide. R1.
So would you like to go into slideshow mode, Dr. Leila?
Oh, yeah, sure.
God bless you. Thank you.
Play.
Just at the bottom. Yeah, just at the bottom right-hand side. Yeah.
Sorry. Yeah.
That's all right. Beautiful.
So this is R1 and it's completely white lung.
Yeah.
Okay.
Yeah.
So I was telling everybody, like, this baby might need surfactant later on. This is R2, sorry, L1. So all the right side were the same. So just I presented one slide for the time. Okay. L1.
Yeah.
Again, here we see subpleural consolidation with some bronchogram. Yeah. L3.
Yep, definitely subpleural consolidations there. Yep, with a complete white lung.
Both sides, like they are symmetrical.
How old is the baby at this time?
He was around 4 hours.
Okay.
Yeah.
Yep.
L5, same.
Yep, white, completely white. Yeah, yeah, yeah.
Okay. Here,
Good slide broad. Yeah.
I was trying to do the trans, but I don't know if I succeed or not. Esophageal. So putting the probe in the middle and then pointing to the shoulders.
Get the diaphragm.
Get the diaphragm. But I thought that was a diaphragm, but I'm not sure.
Yeah, that is the diaphragm. Yeah,
and this is all lung, right? That would be the lung
correct.
here.
Yeah.
Okay. So again, white lung in the same place. Yeah. Yeah. And here, I thought this would be a consolidation.
Is that the left or right side?
That would be the right side.
Right side.
Mm.
It's just the probe is not horizontal. So whether you've got a break in pleural line, because it's you're using are you using the subdiaphragmatic view?
Yes.
Yeah. So I would try to avoid kind of making a diagnosis of it does look like a subpleural atelectasis. Because
there's no bronchogram there.
Yeah. And there's no bronchogram, but you lose contact with the pleura as well.
Okay.
My gut feeling is you probably have a little bit of subpleural atelectasis there.
Okay.
So I mean, there's good going RDS in this baby. Yeah, good going RDS. Did he need surfactant?
So what happened? He was fine until 24 hours of life, and then around 40 hours of life, the baby desaturated. And they tubed him and gave him surfactant, but actually he had perforation, he remained at 25% oxygen.
Sure. Yeah. Okay, interesting. Yeah. Very interesting case. But yeah, I would probably agree that's decent RDS that you've got over there. Yeah.
Okay. Thank you very much.
My pleasure.
That's everything we have here.
Thank you.
Just stop sharing.
We have Kirti. Yeah. Dr. Hassoon will be joining us at 1:45. So
shall I share then?
Yes, please. I'd be very grateful.
It's a very short case. I just wanted to show the slides of diaphragm.
Yeah, you've got the diaphragm there. Very nice.
So this was an extreme preterm baby at 26 weeks, 580 gram, who was now 3 months old on a low flow of 20 cc.
You can go to a slideshow. That's so kind of you. I'm so grateful.
My linear probe has the maximum frequency of 8 Hz, and I've tried using auto gain and sharp to optimize the image. This was the first one. So here I tried to take it in the lateral area between the 6th and the 8th intercostal space, and I kept it of about 2 centimeters.
Very nice.
And this I tried to measure. So as Dr. Adil had mentioned, that you take 3 of each, inspiration and expiration, and then I took an average of each of them, and using the formula of Ti minus E upon E. So that was 33% as diaphragmatic thickness fraction. And he said more than 30% is considered as normal.
Yep. Very good diaphragmatic excursion as well, just visible to the eye. Very nice. So just what is your baby on? Tubed, intubated, ventilated? And
no, he's just on low flow.
Amazing. That's, I mean, yeah, it's beautiful diaphragmatic excursion. What is worker breathing like clinically?
So he has some intercostal recessions, and respiratory rates are always between 60 and 70, but really not in much distress.
Very nice.
And this was the second one, where I had kept the probe between the mid-clavicular line and the anterior axillary line, and I kept a depth of about 7 centimeters. And in order to make sure that it was perpendicular to the diaphragm, I had to change the angulation. And then to look at the excursion, and then I took the 3 average of 3 of these, which came to about 5 millimeters. And in Dr. Adil's talk, he had mentioned that in preterms, it can be up to an average of 6 millimeters plus minus 1. So I thought
normal.
this was okay.
Yep.
Okay.
Very good. Well done.
Thank you.
Does anybody have any other cases to share? Because Dr. Hassoun is going to be a little bit late. So there's definitely an opportunity to see one more case before I start my talk.
Hi, Alok. I can
Go for it. Go for it, Doris.
It's not as interesting as Kitty's on every or anybody, any other person's on. It's just a simple scan I had. Okay. Okay, so this was the scan I did. Sorry, it's not moving. Okay. So this was a 29-week, 29 plus 2 week, 1.15 kilograms at birth. Mom had 2 doses of steroids and Maxol, and baby was born by emergency section because of suspected abrupture. Baby was born in quite poor condition, and you can see that from the arterial cord gases that were done. But baby responded to resuscitation and, with IPPV, was intubated, given Curacef, and transferred to the unit. And after the Curacef, was ventilated with volume guarantee of 5 mL per kilo and in air. And I was because of the poor stats, I think I was a little bit doubtful and suspicious of how the baby would be. So I did a long ultrasound at 8 hours of life. So these were the X-rays, initial X-rays at birth. And I think the first X-ray was done while they had inserted the lines, and they repositioned the lines and the ET tube and repeated the X-ray again. And that's the new X-rays on the right. So I started with the left side, and you can appreciate the pleural looks very irregular, and with lots of micro consolidation. I think there is pleural sliding, which you can see clearly, and you can see quite compact B lines. This is clearly an A profile. I couldn't see sorry, B profile, sorry, I couldn't see A lines, sorry.
Yep. You're absolutely right. Doris, my only comment would be you don't need 5 centimeters of depth in such a small baby. It just also helps your image, because what happens is you basically get a dark area at the bottom. Even if you use 3.5, that would be fine, but it's a beautiful image. And again, if you look at the differences between the pleura of a term baby that Leila showed us versus the pleura here, and again, the severity, this baby has good going RDS. You've got subpleural consolidations all the way through. You've got one small deep consolidation in the middle. You want to point to that? Yeah, just there. Again, now the point is it kind of has its origin from the pleural line. It's fallen back. So there's probably a little bit of atelectasis there. But yeah, beautiful. Yeah, I would agree with your findings completely.
You know what? I do not adjust, the settings have been preset. So when I adjust, they
default back. So what you need to do, and I'm on the unit this week and I'm hoping it won't be crazy. You need to press the frequency button and keep it down and then change once. And that basically allows you to go out of the preset setting. I'm going to show you some image optimization in my talk today and how you do it. Yeah.
Okay. And then this is L2. We can appreciate how irregular the pleural looks. There is pleural sliding, but lots of subpleural consolidation that we can see clearly. B lines clearly, and these are A lines. I thought this was at this point was a double long point. I hope I'm correct. And I put this down as an AB profile. I don't know if
I would probably call it a B profile, maybe with a little bit of lung aeration, because you got basic AIS. Maybe, there's some A lines coming in deeper, but yeah, possibly a double lung point. You're probably this is because L2 is coming, you're getting the diaphragm there. And I just think you might have a small effusion there as well, just below.
Yeah.
It's very different.
Right
Yeah, there, that pocket, absolutely. But the question is that spleen coming in with the diaphragm as opposed to A lines? Often when you go that low and you start getting the spleen in, the question is whether those are A lines or that's just maybe the diaphragm coming into view with the spleen below that. A little bit tricky, but what I'd say is definitely reduce your depth.
Okay.
Yeah.
Okay. And
Beautiful image, yeah. Very nice image.
I
Yeah.
appreciate that how irregular the pleural is, pleural consolidations, pleural sliding, and I mean clearly a B profile. I couldn't see any A line.
Yeah.
And for L5, you could I don't know whether these are subpleural consolidations or air bronchograms.
I would label them subpleural consolidations. I would, yeah. And what you can do is if you're confused, you can zoom into that zone, reduce your depth, go. So this is a really good way of trying to differentiate them is you can reduce your depth to 1 to 2 centimeters. You don't need to alter the focus with the GE, and it will basically concentrate in that area. And that basically allows you to zoom in.
Okay.
The other thing, obviously, with the GE is you can actually, there's a mode on it which basically allows you to see the pleura a little bit better with the sharp mode, which I don't think you have on at the moment, but I can show you how to use that. But yep, I would agree. Subpleural consolidations. Yep.
Okay,
A B profile.
Yeah, the posterior axillary line to try to view the posterior aspect because I couldn't turn the baby. Okay, so clearly a B profile. I thought there were some comet tails.
Yep. Your odd comet tail, especially to the left of the screen. Yep.
Yeah.
Lovely.
R1. So R1, the pleura is irregular, but much better than on the left side, as we can see. We can still appreciate subpleural consolidations. To the right of the screen, it's almost white out. Those are B lines. I mean, they're almost white out. And these are A lines also.
Very good. These are A lines. This I completely agree would be. And whether this is post-surfactant?
Well, this certainly post-surfactant 8 hours after the baby was born. So 8 hours after surfactant, was given.
So the right lung has had a little bit more than the left. You know, you've got aeration of that right lung, and that is often the case, and especially the upper areas often get better aeration. So you've kind of got a double lung point there.
Yes, I thought so. Yeah. The ET tube on the first X-ray was quite far in, so I don't know if they gave the surfactant with that, because if they did, then that will account for why the right side is more aerated, with most of the surfactant going to the right side there. So R2, you can appreciate the pleural, regular pleural, so pleural consolidations, mainly a B profile, and I think this is the long pulse.
Liver.
Wait. Liver. This is the liver.
Yeah, liver with
long pulse. Can you describe this as the long pulse, or it's just the liver?
My gut feeling is it's moving very slowly. My gut feeling is it's just normal sliding. I don't think there's a lung pulse there. Yeah.
Okay.
I might be wrong.
No, you're probably right. You're the expert.
No, I'm not the expert actually. Yeah, we're still, all of us are learning. And I think the beauty of the learning phase is, so you must always trust your clinical correlation, your images, because you're doing them and you know exactly where you are. But yeah, I would think that R3, again, you've got a double lung point there.
Okay.
Yep.
Yeah. Okay. And then at these dynamic air bronchograms, I thought I think
the subpleural consolidations.
Subpleural consolidations.
Yeah,
okay.
Yeah.
And more of a B profile. I see very few lines for more of a B profile.
Yeah.
Okay, and R5 taken at the posterior axillary line. So pleural sliding, irregular pleural, so pleural consolidations.
Yes.
Being clearly, I saw, B lines, but And I think I saw some A lines. I don't know whether I'll describe this mainly. I think this is probably a B profile.
This is a B profile. For me, it's a B profile. You've got an alveologram at the top with, subpleural consolidation, a little bit of atelectasis in those areas. And you're right. I mean, technically, when the baby breathes in, theoretically, you see the B profile shrink a bit, and that's when that A line in the middle appears. But when the baby expires, it basically becomes a total white kind of an appearance. So compact B lines in inspiration, and then when he expires, it basically coalesces together. So a B profile, yep.
And these are clearly subpleural consolidations, are they not air bronchogram?
I would call them subpleural consolidations, yep.
Okay, so I think I gave a BRAT score of 8, and I thought it was more of an AIS pattern with lots of B lines. Baby was ventilated and still in air. And I mean, when I did this scan, baby was in air, minimally ventilated, and I was a bit conflicted looking at the ultrasound findings. It was, when should I think of extubating this baby? Baby was minimally ventilated with very good gases, but looking at the ultrasound findings, so I was in a bit of a dilemma because clinically baby looked stable. Ultrasound findings looked like I should be giving the baby another dose of Curacet.
So what I'd say is, what we don't know is what the lung ultrasound findings were before. Okay. And I think if you had serial lung ultrasounds, I mean, you have the right lung, which is decently well aerated.
Okay.
Kind of with a double lung point. The left lung, I would agree, is pretty solid in terms of having quite good going RDS over there. And the BRAT score, again, just to say that when Rosalind Bratt did the study, the sensitivity and specificity for the second dose of surfactant was not evaluated as well. My feeling is, in this situation, you must never disregard the clinical status of the baby. You must always correlate with the clinical status of the baby. And if the baby is telling you something else, your lung ultrasound shows some, an option there is give him a little bit more time and reevaluate and see. And I mean, if he continues to improve, the work of breathing remains stable, then I'd probably, if this baby's in air, give him a go, a trial of extubation, and see how he manages. And again, I always say clinical correlation is absolutely key. So look at your baby, and sometimes you get conflicted by the ultrasound, but it's very similar with x-rays as well, where I occasionally get babies who I've done an x-ray on, which looks like moderate RDS, and I'm just debating, should I give him that second dose of surfactant at 12 hours? I think if you extubated and gave him a go, you'd be as right. If you gave him another dose of surfactant and extubated, you'd be as right. But following the clinical course, if you kept him tubed and didn't give surfactant, is also an option. So all three on the table. Yeah,
well, interestingly, I just left the baby alone, and a few hours later, we had to extubate him because he was getting over ventilated. It was just crack on and see, and she was okay. Yeah.
So 29 weeker.
Yeah, 29 weeker.
And antenatal steroids.
2 doses, but was born in poor condition because of abruptio placentae, poor cord gases. So I think I was being very cautious because with a bad start, I was anticipating problems. So I saw the long ultrasound and I was like, okay, maybe it's going to be bad, but clinically, baby looked better. So I just went with the clinical correlation and extubated, and she was fine.
Lovely. Well done, Doris. Doctor, who's got the hand raised? Somebody's got the hand raised.
That's me.
Yeah, go for it, Dr. Zaruddin.
That's a hypothetical question, because this is a very interesting discussion. That's Dr. Doris. If you haven't had the knowledge and the skills of doing a lung ultrasound scans, what would you have done with this baby, having him in a minimal ventilation settings in air?
Yeah, that's a good question, Dr. Zaruddin. Because it would have just, just extubate. So yes, so would have gone with the clinical correlation, because in air, breathing well, stable, it's very good gases. Yeah, just go ahead and extubate. Yeah.
I will go with the option too.
Yeah, thank you.
I would completely endorse it. And what I'd say is, again, when we do a lung ultrasound, I mean, this is a 29-weeker steroided. Was she a girl?
Yeah, a girl.
Yeah. We all know that the opposite sex has just got better protoplasm than us. And I think the other aspect to it is when you're doing a lung ultrasound, also look at the activity of the baby. What's been happening? Has the baby been handled? Has he been moved? Small things like that can result in, slightly worse appearance than how the baby is clinically. So take all those factors into account. I mean, we'll be looking at some cases today, which you are going to diagnose, but clearly that, there's some food for thought in how those small things that we do can sometimes make a lung ultrasound look worse than a baby is actually clinically. But the opposite is also true, where you might handle a baby and suddenly the baby's got work of breathing and a lot of problems. But actually, from your perspective, the lung ultrasound doesn't look so bad. So clinical correlation for me, what's happened to the baby, how the baby is, how you did the ultrasound. Was there a struggle? Was he fighting? Were there issues that may have compromised how your images look? You must look at that. I can see that Dr. Hassoon has joined us. We're really grateful, Dr. Hassoon, and
thank you.
Go for it, please. We've seen some beautiful cases today, and I mean, my compliments to all of you who are presenting. Well done.
So this is preterm baby, 36 weeks for normal delivery. GPS unknown and infant of diabetic mother, admitted for respiratory distress and started on high flow nasal cannula, 0.5 FiO2. Then for increased work of breath and high FiO2, intubated and giving Surventa. This one, just X-ray, is showing RDS, but just we did it, we didn't have the opportunity to do it before intubation. So we did it at 24-hour of life. If we start with R1, we can see normal thin pleura, well sliding, some B-line, and also AB profile with thin pleura and good sliding pleura. This is R1. R2 also the same. We have thin pleura, good sliding, and mainly B profile, lateral side, but with many B-line. And I don't know if we can call it subpleural, some small subpleural consolidation here on R2.
My feeling is more comet tails.
Comet.
Yeah.
Okay, fine.
For me,
yes.
Yep.
Sorry.
So just again, the pleura looks quite regular.
Okay.
You've got just when I look at R1 as well, you've definitely got a B profile. All I'd say is you can reduce your depth. What's the baby gestation and weight?
Gestation is 36 weeks.
Okay,
and
it's term
weight
baby.
2.3 or 2.5.
Okay, so it's decent sized. 4 centimeters would be enough. What frequency are you using?
Yeah, this is Siemens linear probe and 12 hertz.
Yeah, you can drop the frequency, sir. Just it'll give you better depth.
Okay. Okay. Yes. I did it last time, the last baby, and it worked. So we can decrease it by percentage. So it go down to 8 hertz, and we can go up to 12 or to 13 hertz. So here are 3 subpleural consolidation.
Yeah, definitely subpleural consolidation.
Consolidation and B profile and good sliding and irregular pleura. This one, and then we will go to R4.
Yep.
And here I want to see, this is the snowflake sign of RDS. Yes or not?
Yeah, that's the snowflake sign. So can I just say, this is a beautiful comparison that you see over here. This is the snowflake sign. The pleura is, it's very thin, barely visible. You've got a complete white lung appearance here. And that is the snowflake sign. I would agree. Yep. Okay. Good going RDS.
Yes, just I did it to see if I can have the feature of RDS on ultrasound.
Yeah.
And even he received 1 dose of Surventa. So if we go to the left, L1, also pleura is sliding, thin, B profile mainly, with comet tail and a yes, but no subpleural consolidation. Yes. Okay.
I would agree.
So L2 also we have good pleural sliding, thin, some B line and A profile also.
Yeah, can I just say that your image on the right, can you see why it's so important to have a perpendicular probe?
Yeah.
So what is happening is when you lose your perpendicularness, what those subpleural consolidations that you can see, some comet tails, they They disappear completely. They appear more like comet tails when you lose your profile, but actually there are some subpleural consolidations there. So
this is
yeah. So very important that we try to keep the probe as perpendicular as possible. Yeah.
I don't know if you have this problem, but some baby really on
big ones.
Big ones. We are struggling to get this view, especially left side.
Yeah.
And here R3, sorry, L3. So pleura is irregular, sliding, and also subpleural with a snowflake sign. The other one also here is obvious. This is we can call it this one shred sign, no? Hello?
No, I wouldn't call it shred sign. This is basically subpleural consolidations with atelectasis. It's just it's a higher grade of subpleural consolidation, kind of grade 4, very similar to a snowflake sign with sliding. The pleura is not visible. That would not be shred sign. No, I'll show you shred sign today. Yeah.
Okay. So and there is static air bronchogram, or we cannot call it.
My feeling is there probably is a static air bronchogram on the left side in the middle. Just the right-sided image, just below that.
Okay.
Yeah, but that's basically broken down pleura, subpleural consolidations, microconsolidations with atelectasis.
Atelectasis.
Yeah.
Okay, I didn't put the Doppler study to see.
You don't need to. You don't need to. This is basically superficial to the pleura. So really what you'd be using Doppler is to differentiate a focal area of large atelectasis.
Okay.
Yeah. So, my gut feeling is this baby's got good going RDS. Even though there's some areas that look very nice. What was this baby? This was post-surfactant, right?
Yes, post-surfactant. It was 8 or 10 hours post-surfactant.
Yeah.
All CRP negative. This baby got extubated after 24 hours and discharged home after 5 days.
Yeah.
Well, thank you. This is just my kids to see this is the snowflake sign or not.
Beautiful.
Thank you.
Beautiful.
Thank you.
So I've got some questions. What is the difference between? So there's no difference, Dr. Doris. So in the chapter on RDS, what you'll find is that Dr. Liu and his colleagues have just recently written an article. I will try and find it and send it to everybody, where they have tried to classify the severity of subpleural consolidations. The mild kind of appearance would be a ground glass kind of an appearance of subpleural consolidations with not much atelectasis. But when you have micro consolidations with atelectasis, so that you lose your pleural line and you can't see the pleural margin, then it appears more like snowflakes just under the pleural margin. And that indicates a severe grade of RDS. And they've tried to correlate that with the grades of RDS as seen on chest X-ray. So they've come up with that classification. So it's just another way of kind of saying that this is a severer form. And Dr. Hassoun, Dr. Zaradin had a question about the FiO2 and the vent settings.
FiO2 was after intubation, we decreased the FiO2 to 0.3, and after that on air and with decreasing pressure, the second day was extubated.
Well done.
But at that time, it was FiO2 0.3, if this is the question.
Okay. I'm just going to share my presentation. Today, again, it's a workshop. It's going to be very interactive. So just very quickly share my screen. You're the bosses. You're going to help and you're going to make all the diagnosis. Okay. Am I visible and audible?
Yes.
Okay, so can I just say that so far the lung protocols that we've covered have covered two things. So we've covered the presentation of respiratory distress at birth. We've covered late respiratory distress with a few cases and case presentations. But now really, I'm going to cover the third protocol, which is basically the importance of lung ultrasound in the baby who desaturates acutely. I apologize, I've repeated it twice. A little bit more trigger happy today. But really from our perspective, whenever you have a baby on the ventilator, having a structured approach clinically is very, very important, because really these babies need to be evaluated and there can be multiple differential diagnoses based on the underlying pathology, the clinical stage at which the baby is presenting with desaturation, as well as the fact that there may be other pathology other than just airway respiratory that might account for some of these changes. Now, Desaturation and how you define acute desaturation can vary. So you could have a drop in sats and heart rate, which is a crashing baby, versus a gradual drop in saturations and heart rate over a period of a few hours, which again then culminates in an acute presentation. Or you might have what I would say is a trend analysis, which basically shows that the saturations have been gradually deteriorating, and we've probably reached a tip-off point. But if you look at the clinical approach to how we do this, I mean, with all these causes, you clinically assess, you review the baby, and just a structured approach that I do is I will go back to airway breathing, the tube position, go through the dope kind of mnemonic, make sure that the tube is not displaced, obstructed, there's no pneumothorax. Obviously, that theoretically our equipment is working. It's not kind of a situation where we've got a ventilator that's starting to malfunction. But once you've kind of made that assessment, and if you're kind of in a situation where the clinical assessment shows the significant work of breathing, there is maybe asymmetry in the clinical presentation, you have better air entry on the right than on the left side, or you have a baby who's recessing against the ventilator with a trend analysis or a gas that shows deterioration, rising CO2s, worsening FiO2, then really what you're looking to do is do some investigations. And the options now, in addition to doing a chest X-ray, are doing a lung ultrasound. I think whenever you have situations like this, especially in babies who present just after birth, but also babies where there's an open duct, post-ductal saturations, just to make sure you don't have a difference between pre and post-ductal saturations is important. But I just want to come back to that structure that we've always talked about. So you must think about your clinical presentation, the background of the baby, but common things that you think about based on this presentation, you definitely want to exclude a pneumothorax. And once you've excluded a pneumothorax, clinically, chest X-ray, or by lung ultrasound, really there might be other pathologies that might explain why this baby is getting worse. And that might actually then culminate in a management decision that you will make in order to try and make this baby better. Always clinically correlate. And once you make your management decision, whether you're diagnosing a baby who's deteriorating with pneumonia or sepsis and deciding to start antibiotics, whether you've got a baby who has evolving BPD, who has a problem with maybe atelectasis, a collapse consolidation in a particular area of the lung, secretions, maybe evolving kind of microaspirations secondary to reflux. These are all situations where you might see deterioration for the baby on the ventilator. And then we often see babies who deteriorate with a dropping PVR. And at least for those of you who believe that the duct can create problems with the lung, as the PVR drops, the PDA floods the lungs. If you have another left to right shunt, that might also be a problem. And then you can get lung edema. But these are all diagnoses that can be made by lung ultrasound and chest X-ray, culminating in a management decision where you will make a change. And really what you need to then be able to demonstrate is improvement. Now, pneumonia and sepsis will take time, and it might mean that you have to do and manage symptoms in this process. That might mean that you have to increase ventilation, recruit lung. And the next Sunday, I will be talking specifically about recruitment maneuvers and how we use lung recruitment strategies in situations like this. That might be the case for BPD atelectasis as well. But if it's worsening lung edema, again, PEEP, diuretics, if you believe in them. And if you have a pneumothorax, obviously it might need significant intervention to treat that. But please stick with this protocol of thinking and clinically correlating, making a mental model of why you think that is the diagnosis, and then basically a management decision that theoretically should improve things. If you're confused about the diagnosis and you have another colleague who can review lung ultrasounds and you can do peer review, do that. If you're still confused, I would say go for a chest X-ray. And in the learning phase, I would always encourage you to do a chest X-ray to try and correlate your clinical diagnosis. The most important other thing is if your lungs are completely barred or normal and you have reasons for the oxygen going up, then just think about other causes other than just the lungs. So now what we're going to do is groups of 2 again. So who'd like to go first?
Okay, I'm all right going for it.
So we've got Doris. Who wants to help Doris?
I will help Doris.
Okay, Leila, beautiful. So what we'll do is we'll let Doris give her opinion, and then we're going to do the mental modeling where we'll see what Leila thinks and try and see what we think. So I have a preterm baby who is 24 weeks of gestation. This baby is ventilated for 2 weeks. Background is delivering in a setting of kind of pre-prom since about 18 weeks of gestation. The lungs didn't look very bell-shaped, but had really good going RDS. I mean, this baby was on high ventilation settings, had an element of PPHN diagnosed clinically with also echo findings, had a trial of nitric, which basically helped the baby alongside the surfactant. And actually, by the end of the first week, had come down to kind of ventilation settings where we were VG'd on decent, volume guarantee, about 5.5 to 6 mils per kilo, needing decent pressures. The CRP during this period rose to 27. The baby had completed about 10 days of kind of antibiotics. And as I mentioned, we're kind of about 15 days, 6 mils of VG. The pressures in the morning were kind of on the ward round 24 to 27. We were achieving those tidal volumes. We were about 60% FiO2. The baby kind of had evolving lung disease on the X-rays. The gas was more than acceptable. But about kind of 9:30, people came on for the evening round. And when he was reviewed by the multidisciplinary team, clearly, needing a higher pressure to achieve 6 mils per kilo on the VG, they put the PEEP up to try and recruit this baby because the baby was recessing against the ventilator. There was work of breathing. But in FiO2 of 100%, this baby had SATs of 80. And your gas basically was a pH of 7.1 with a CO2 of 73, which equivalent is about 10 kPa, kilopascals. Do you want any other details, Doris?
Okay, you talked about the CRP going up to 27, and this baby is 15 days old at this point. So at this time, was sepsis excluded? And was there a PDA?
Okay, very good. So no heart murmurs that were audible. Clinically, the baby had completed antibiotics, a good kind of 10-day course. And the CRP had basically come down to, I think it was 10 or 12. Okay. And kind of once it was coming down, we kind of decided with culture negative sepsis that 10 days should be sufficient. And at this particular point, the baby is not on antibiotics.
Okay. And I take it that this is the same, the baby has been ventilated since birth. Was there lots of secretions? Were they suctioning lots of secretions? Was there a possibility that the ET tube was blocked?
Clinically, on examination, they went through dope and they didn't think the ET tube was blocked.
Okay. Okay.
Good kind of color change on a pericap, kind of routine clinical approach. Good loops or flow loops were visible, inspiration, expiration. And really, I mean, the baby clinically they felt was ventilating. So no equipment failure. Didn't clinically feel the baby had a pneumothorax at that point. Was transilluminated, it was negative. So if I just show you the ultrasound, so that's L1.
Okay. So looking at this, you can see the pleura. It is irregular. I would say it's a little bit, it's fairly irregular, but it's continuous. We can appreciate pleural sliding clearly. And mainly this is a B profile. I can't see any A lines. Okay. So this is all B lines, yeah.
Yeah. So kind of AIS?
Yes.
You're happy with AIS? So I wouldn't quite label it white lung yet until I've seen the other lung zones. So J-Lu's definition is for white lung. You should be able to demonstrate this in all regions. So that's L1. Dr. Leila, do you agree?
Absolutely. I mean, it could be IS, but I would like to see other parts of the lung.
So take my word for it to say that I did L2, L3, L4, and they were exactly the same, pretty much. Mm-hmm. Maybe compact B lines visible in L2, but exactly the same finding. So kind of a white lung kind of an appearance, but with pleural sliding everywhere. So no evidence of a pneumothorax, but good going, what looks like evolving lung disease. Mm-hmm. And this is R1.
So R1, the pleural looks very irregular, as we can see. and lots of subpleural consolidations, and can I say air bronchograms also on the right-hand side of the screen. I don't know.
Yeah.
Yeah. Yep. Okay. And there is pleural sliding, and this is also a B profile. I can't see any A lines. This is in R1, yeah. And then is this a deep consolidation on the right side, the lower side of the screen?
Okay. What do guys think?
This point. I don't know if
So Leila, yeah, there's I just gonna focus in this area
Yeah,
here.
I see bronchograms. I see bronchogram, and they are static. Yeah,
Very
static
good.
bronchogram.
Very
so
good.
it could be consolidation, deep consolidation. Yes. So I would put
Okay.
my Doppler now and see if that would help me.
Okay. Okay. Why is the pleural line not visible?
Probe, yeah, contact with the probe.
Okay.
I
very
mean, the
good. So
fluid,
could
the
be-
fluid is the fluid and the consolidation might prevent the reflection of the pleural line, right?
So
Or air.
it's a little bit confusing, and I would completely endorse that. It's really important from our perspective that we try to get the probe as perpendicular as possible. I go down to the right lower region, and what do we think? So this is basically R2.
Mhm.
So R2, yeah, pleural looks thick, but there is pleural sliding, and clearly B profile. I can't see any E lines at all. Compact.
And
Micro-
subpleural consolidation as well.
Yes, I agree.
Okay. So I mean, I'm just thinking of our differentials. We certainly don't have a pneumothorax in either of the L regions, or at least the right R1 and R2 regions. There's that area in R1.
Yeah.
So what I've done now is I've basically reduced my depth, and I'm trying to get as perpendicular as possible, and trying to focus to optimize my image. And what can I see?
The pleural effusion, is that fluid?
Okay, so for pleural effusion, you should have fluid between the pleural lines. So let's think about. So let's go back to our basics. Can we see a bat sign?
No.
Okay. Okay, so let's say that this is the bat sign. Then you have a rib over here, and you lose everything here. You lose your pleura. Okay.
Okay.
You've lost your pleura here. You agree?
Yes, yes.
And then you've got an area here, which is.
Sorry, we can't see your pointer. Is your pointer?
That's your pointer, yeah.
Yeah. Okay.
So, can you see any pleura here?
No.
Okay. And in terms of tissue, what does this look like? Does it look a little bit hepatized to you?
Could be. I mean, similar to the.
Yeah. And what you've got is you've got these micro consolidations over here.
Yes.
So what this in my mind looks like an area of probably atelectasis is my worry.
Because you don't see bronchograms.
But also I can see a lung pulse.
Yes.
And I can see static bronchograms. These are static bronchograms, not dynamic.
This one here.
So if it was,
can you use your pointer to show what where you're looking at? Your pointer? Yes, please. Yeah.
so some people would interpret this as a fractal sign. It's going to be a little bit tricky for me to show it to you that way with the pointer. Can you can't see the arrow.
Yeah, we see the arrow. Yep.
Can you see the arrow?
Yes.
Moving. Okay. So can you see the arrow here?
No.
The arrow is not moving.
Okay. Can you see the pen now?
Nope.
Can you see the pen now?
Now we see it, yes.
Okay, beautiful.
Yeah.
So that's pleura all the way
Yes.
through.
Yep.
Okay.
Yes.
Now what happens is pleura basically drops away from the margin here. And then you have a large area over here, which basically looks quite dark and hypoechoic. Okay, this is atelectasis. There's pleura here, and then you basically have an area of what are air bronchograms. So if I just play this again, can you see this? Can you see this is lung pulse?
Okay. Yeah.
So it's never easy to make these kind of diagnoses, but this for me is an area of atelectasis. And you have dropout most probably because you have a rib that's coming through, which is giving you that shadow. These ribs are quite crowded and close together. So because they're crowded and close together, you have a little bit of dropout. Okay. Now, my question to you is, what are you thinking?
So,
okay, go on.
Okay. So multiple subpleural with atelectasis, recruitment for lungs, maybe sedation for this baby.
Okay, that's true. So let's go back to airway breathing, structured protocol. So where is this? Which part of the lung?
Right side upper.
Okay, right upper. So you've got a whiteout AIS appearance in virtually every other lung field on the left and the right. But you've got this area that is very focal in the right upper zone, which basically looks atelectatic. Pleura is moved away from the margin. It's broken because you have no pleura visible. You probably don't have aeration in that region. And then you have some air bronchograms with aeration to where air can actually reach, which is this region here. Okay. Or a deeper consolidation. So if you have a right-sided upper lobe consolidation collapse, what would you be thinking of?
ET tube.
Okay, so let's have a look at the ET tube. So this is the suprasternal view. Okay. So this is the aorta coming into view. This is the ET tube. It's better visible in the next one. See it?
Yes, it's deep.
ET tube is too far, isn't it?
Yeah, it's so I can see it right beyond the aorta up till here. Can you see the marker there? See this? Can you see this coming through?
Yes.
Yes, yes.
So that ET tube is very low. It should be a centimeter above this margin of the aorta. This is the arch. This is the arch. Can you see the pointer?
Yeah.
Flow through the arch. There's an ET tube coming through there. Now, see? That's the ET tube. It's coming all the way down. It's crossing the arch. So it's low. So, I mean, this still could be maybe a collapse consolidation, much better visible now. Can you see it?
Yes.
Yes.
Can you see that? And when you look at it in this image, it's here.
Yeah.
So that's a very low ET tube. So normally what the ET tube, when it's at the carina, should be 1 centimeter above this margin of the aorta, at least 1 centimeter above. This is well below. So this will most probably be down the right main bronchus. And that is, what I'm thinking. But what is also very visible to me is because you've got a right-sided collapse consolidation. So I'm just taking you back to this image and mental modeling. Mental modeling is very, very important. So what is happening here is the left lung is basically overinflated, coming in the way, and that's why it's making it so difficult for me to get the aorta. I should be able to see the aorta in the suprasternal view quite easily, but you can see the ET tube all the way down, and you can see it very clearly. Okay, so what do we need to do?
Pull the tube out.
Yeah.
Okay, so now let's pull the tube back. So what I've done is I've dropped my gain, and I'm pulling the tube back. Can you see?
Yeah.
Yes.
Oh, yeah.
So I'm just dropping my gain so that I can see the tube going back. And it's pulled. This is the margin of the aorta. That's the tube there, 1 centimeter above. And once we'd done that, we clinically had improvement in the baby.
Okay. Can I ask, did you do a chest x-ray? You didn't do an x-ray. You made this diagnosis on the lung ultrasound alone.
Yeah. But what we did is we did screen and start antibiotics.
Okay.
I wouldn't risk it. I would never risk it. And that's where discretion is the better part of valor. So our CRP was, I think, 603 or something like that. We never cultured anything. But really, from our perspective, this is something that you must be very careful about. Okay.
Thank you.
Does that help? And again, what I'd say to you is it's just coming back to the images. It's not as clear cut, and I agree. But for me, it's a diagnosis that I'm making by looking at the rest of the lung as well. I'm kind of wondering, why is it that I have an AIS pattern kind of white out in the rest of the lung, but I've just got this focal area in the right upper lobe, which, could it be a fractal sign? The problem with the fractal sign is, it's very focal, very kind of, and this area basically looks like it's definitely got static bronchograms. I think you've got air there, and you've got an area of atelectasis that you can see over here.
Mm.
This entire area is atelectatic, and I think it's because you've lost your right upper lobe. I haven't done a chest X-ray, but as my baby's clinically improved, I mean, theoretically, from my perspective, I've started antibiotics. I don't really need to do a chest X-ray. What I might want to do is look at the duct, and I did look at the duct. And in the aortic view over here, I mean, you can see a small duct. When you actually look in the ductal view, it wasn't a large duct. In fact, the PVR was still quite high. So it's more important rather than ductal size to actually measure ductal shunt and try to evaluate that. So next case, who wants to have a go, guys?
I can try.
Who's that?
Anna.
Anna, that's great. Anna, who's going to give Anna a hand? Dr. Hamad, would you like to give Anna a hand?
I'm happy to.
Yes, I'm happy to. Sorry, I was
No, that's
trying
right.
to find my mute button.
Okay, no, that's all right. Okay, so let's just say this is a baby on a ventilator who's developed acute respiratory distress. That's the history I'm going to give you. Suddenly desaturating. FiO2 shot up to 100%, your saturation is about 70.
Okay. The baby is on the ventilator, right?
Yeah, on the ventilator. It's a term baby. Intubated, ventilated for respiratory distress and respiratory acidosis.
I think I can see a really clear sliding in these images. I don't know if it's I'm looking to a small ecran today, but I think there is no so much sliding.
So you feel there's no sliding?
Yes.
Right? Yeah, excellent.
It's moving
okay.
with the respiration only.
Yep.
With the chest.
Yep. I would agree. Anything else?
I think we can see a truck sign.
Yeah, you can see a truck sign. Anything else?
And A-lines.
Yeah. So what do you think your diagnosis is?
Pneumothorax on the right side.
Yep. Dr. Hamad, what do you think?
I think I agree with the sign she's mentioned as well, but I'm not quite sure at R2 whether you got a liver here.
Yeah.
And then on R4, it looks like there is a gap which may be like maybe air, because this is completely black below the pleural lines.
So it's not a very good quality image. I'm losing my image as I move because of the activity of the baby. But do you think there's pleural sliding there? Yeah.
There is some, yes. And then there is subpleural consolidation on the R4 as well.
My gut feeling is that's not a subpleural consolidation. I think you've got rib dropout over here.
Mm-hmm.
And the darkness at the bottom is basically because I haven't got a good alignment. My gut feeling also is I'm running out of jelly and I should probably apply more jelly and reapply. But I just look at this margin here and look at this margin here and kind of, can you see what looks like a comet tail here?
Yes.
So if you have a comet tail here, you must have sliding over here.
Mm-hmm.
But you have an A profile over here. And do you think there's sliding there?
There is some sliding, although the pleural lines looks a bit thick.
Okay, fair. I mean, what I'd say is that absolutely right. You've got an anterior pneumothorax at this particular point. Small or big?
I think it's small, depending on the baby's condition. clinical condition, then
what did we say about the baby's clinical condition? Desaturating, 100% oxygen, SATs of 70.
Then that might be attention even pneumothorax because of the desaturation and need relief by emergency thoracotomy.
Yep.
I think we have air in the R4, so I think it's big.
Yeah. So this is really important, that the way you're quantifying your pneumothorax is based on clinical correlation. I mean, I'm just giving you the fact that, if you look at above to below, you've got air all the way from the top. I mean, that's thymus for you. That's coming in there, a complete A profile. So that's all the ribs down to the liver. So there's air all the way there. And when you move laterally, my gut feeling is, I think you have sliding up till here. I'm not sure that you have any sliding in this area here. And this is the posterior axillary line. That's why I've written that this is the posterior axillary line, is that if you have air all the way to the posterior axillary line, that's a fairly decent pneumothorax. So let's have a look at the left side. Let's see what you think about the left side.
On the first scan, is there thymus in the left side?
Yep, that's thymus. I agree.
Yes.
That's thymus. Yep.
And there is an A profile.
Yep.
Where in midline shift? Because the thymus should be seen on the left side, isn't it?
Very good. So again, just another indicator of the severity. I mean, your thymus is, and classically, if you remember, when you have a pneumothorax, and in particular, if you have a bilateral pneumothorax, then you get the sale sign. Thymus gets outlined on both areas. But is there any other marker that will tell you that there's significant mediastinal shift? So you have virtually all heart there. It's very difficult to see any lung at all. I'm really struggling. What do we think about sliding?
It looks normal to me, especially on the one on the top, on the left. For me, on my screen on the right side, the sliding looks normal. And I can see normal B lines and A lines.
Yep. So what do we want to do that I have not done over here? And that I'm not showing you on, you need to do M mode, guys. So I think what I'd say is go back to the basics. So this is a different case from the previous one, where what we're really trying to do is think about pathology in a focal area. But here, clearly, we've got a pneumothorax. And really what we need to be able to demonstrate for a pneumothorax is those 4 signs. So R1, R2, up to R4, you've got a lung point, you've got 3, and really M mode in this situation showed a classical barcode sign. I've taken it off just because I want you to think. And really over here, when you put M mode in this area, we basically got a seashore sign. So there is basically lung sliding that is clearly visible. Also, from our perspective, significant mediastinal shift, but it's very, very obvious when you actually go to L3. So when you look at L3, you have a B profile with some A lines and really good pleural sliding. So big pneumothorax on the right side. From our perspective, had a very small pneumothorax on the left side, but this was a baby who had a needle thoracentesis and a chest drain on that right side. So again, you can make a diagnosis of this situation where a baby is desaturating on the ventilator, if you think of your differentials. And the scan took very, very short period of time for me to do while I'm waiting for the chest X-ray to come. So, we needled based on clinical diagnosis even before we did the chest X-ray. We didn't wait, and we had furious bubbling to the point where, we got ready, the baby clinically improved, saturations improved. We then did the chest X-ray, confirmed, and we went for a chest drain because there was still residual pneumothorax on that. So again, very powerful tool in the right, if used in the right way in a baby who's ventilated. Who wants to have a go at this case?
I will.
Okay.
Yes, me too also.
Okay, so it's Dr. Hassoun and Dr.
Rana.
Dr. Rana. Dr. Rana, I'm sure. I try to figure out by remembering voices. So gradually I will, yeah, I will. So this is a 23-weeker twin. These babies delivered having had a single dose of antenatal steroids, both boys. Mother went into spontaneous preterm labor, but she, from our perspective, had significant problems with some APH as well. The babies eventually, I mean, the plan from our perspective was that we'd like to keep the babies in, try and see if tocolysis worked. It didn't, so the babies delivered. And they were intubated, ventilated at birth. They had some surfactant. They ended up with 2 doses. Never been extubated, treated with antibiotics for a period of 5 days with no significant rise in CRP. The reason for treating with antibiotics was basically the clinical presentation, worry of APH. I think a low threshold for us over here because of the profile with which babies present. But on day 15, what we've had is we've gone from about 40% oxygen over a period of time to 100% oxygen with a worsening respiratory acidosis, pH drop below 7.2. We were already on VG at 6 per kilo. So the decision was made to give this baby a trial of oscillation and then do a chest X-ray. But before that, we had an opportunity to do a lung ultrasound. Anything else in the history that you want to know?
Any PDA finding is significant?
So not clinically audible at this particular point over the ventilator, no heart murmurs, and pulse is not bounding. Perfusion is good. Lactates on the gas are normal, but yeah, a CO2s are, they've gone.
Maybe not septic also.
So clinically, it's always tricky. I mean, what it says, well perfused, no cardiovascular problems, but definitely a rising FiO2. So I'll be honest to say to you, we screened and started antibiotics. But to say I didn't have a CRP result when I did the lung ultrasound. Here, we would never risk it in this situation.
Yes. Yes.
Yeah.
Just do the basics. Just ensure that we have done dope and there is nothing immediate we have to do.
Beautiful. Absolutely. Absolutely. So before we do the lung ultrasound, that's exactly what I want to hear. We did dope. We transluminated. No evidence of a clinical pneumothorax bilaterally. We also, from our perspective, kind of, with an oscillator, you want to look at bounce, but just capnography, pedicap, good color change, we went and started with a map 2 above what we normally do. And clinically, I mean, no doubt that the baby had good bounce, sedated and paralyzed as well, this baby, because we were in 100% and we were saturating high 80s actually. So I'll show you the ultrasound. If she lets me move forward. So this is L1 and L2.
Shall I start or
go for it? Yeah, no, go for it. Absolutely. Yes, please.
So on L1, we can see.
I'm not sure about
the quality of this scan. First of all, is just to look at the top where I can see some ribs, but not all ribs. So I don't know whether the probe is just slightly twisted.
You're right. You're absolutely right. So L2 is better than L1. It's slightly twisted.
Yeah.
But you can see
but
1,
we can
2.
see, yeah, but we can still see good lung sliding with the pleural line looks slightly thickened and mainly B profile on L1, but I can see some lung aeration towards the right side of the of L1, so at the top of the left lung. Towards the bottom or the left side of L1, it looks like there is a deep consolidation there.
So that's heart. That's heart. This is very important. I just want so that people understand. That's heart. But yeah, this area here, definitely.
It's
you
the
worry about.
echogenic, that echogenic area.
Yeah. Very good.
So on L2, yes, that looks better. The pleural line generally looks all continuous and irregular, but there is a drop in continuity right in the middle. with some air bronchogram, right? Like it looks like subpleural consolidation right
Very
there
good.
in the middle,
Very good. Yeah.
with mainly just a B profile.
So that's the area of subpleural consolidation that you can see in L1. You're right. And I would say that similar kind of areas that you see over here. So very good. So, I mean, just in terms of your clinical feeling, is there a pneumothorax here?
I don't think there is a pneumothorax.
Okay. Is there a large area of atelectasis collapse consolidation?
Well, it looks more like just
Bad RDS,
bad
worsening, evolving lung
RDS,
disease?
some subpleural consolidation. It doesn't look like there is, that area looks like an echogenic area, which is probably consolidated, but no large areas of consolidation or focal collapse that I can see.
Any fractal sign or shred sign?
Not really convinced. I mean, there is that area on L2 where the pleural line is broken, and there is this area, the echogenic area right under. So, but I'm not convinced that there
Very
is
good.
a shred
So,
sign there.
what you're doing beautifully, Dr. Rana, is your mental modeling. And this is where I'd say that often, and I want you as a group, basically it should be barn door shred sign. And I can't see any evidence of a shred sign over here, just some subpleural consolidation. 3L4.
So L3, there is lung sliding. The pleural line does look broken and irregular, mainly in the middle and towards the top of the screen of the baby, mainly on the area exactly where that indicator is. I can see mainly B profile, but some lung aeration towards the left of the screen, and there are still the areas of subpleural consolidations with just these echogenicities. They look like more dynamic bronchogram rather than static, where that indicator is on L3.
They're more static. So again, dynamic will move in and out. I mean, these disappear and appear with inspiration, expiration, but they stay in the same place. They're not snake-like moving in and out.
Yeah.
So my gut feeling is these are static, mainly this region here. But I completely agree with the other findings that you've described. So what about L4?
So with L4, again, the pleural line looks irregular. There is, but it's sliding, mainly towards the right side, where there is mainly, there is some lung aeration there with some A lines, but towards the left side of the screen, there is mainly a B profile with subpleural consolidations. And again, this, I think the probe is slightly twisted as well on L4.
Yep. You're right. Yep. And you have heart coming in. So what I'm trying to do, and the reason, it's the challenge of trying to get the heart out of the way to try and get the best image. So, but I would completely agree. Subpleural consolidations, static air bronchogram just there. And really, I mean, if you were to mental image here, L1, L3, L4, what do you think?
I think generally it all looks like subpleural consolidation with mainly a B profile. Looks like
some lung aeration. Some lung aeration?
Some lung aeration. Looks more like evolving lung disease.
Beautiful.
Based on this.
Yeah. Now let's have a look at the right side. So you've seen the left side. Using the same gain settings. So just remember, I'm using the same gain settings.
Sorry, do you want me to have a go at that one as well, or Dr. Hassoun? I don't want to take
So Dr. Hassoun.
Okay. So right side also, we have here, pleura is sliding, irregular. So if we start from the left side of the image, there is subpleural consolidation. And also with at the right, also there's some pleural consolidation or atelectasis, because you have static bronchogram. or dynamic, this one on the left, on the right side. On R2 also, here this pleura is sliding on R2, okay, and here I don't think this is like atelectasis because this is a pleura is not obvious, but I can't see. Let me see the air bronchogram because it's not working the image.
Yeah, 1 second.
The loop, it's not working. So, like static also, there's static air bronchogram. Pleura is not broken totally, so and the right and the left. So with some, most probably atelectasis with some consolidation also. I should put a Doppler here.
Okay. Guys, there's a lot of confusion still with static and dynamic air bronchograms. And my gut feeling is I'll probably go through the consolidation and the atelectasis kind of section again. The reason I say that is, so what I'd say is the dynamic air bronchograms, if you see my fingers, can you see me, everybody?
Yes.
Yes.
So they move in and out like this. Static air bronchograms will stay in the same place and they may appear and disappear. Or they may stay there because actually what has happened is air is trapped and can't go back out. Now, theoretically, if you have a dynamic air bronchogram, that's consolidation for you, 100%, because air moving in and out means it's unlikely that you have atelectasis or collapse. But really, for a complete atelectasis from the lung margin, you should not see any pleura at all. Now, look at this kind of L3, L4 image. You can see pleura here. It's broken. It's irregular. Can you see an L3?
Yes.
L4 as well. Pleura is broken. It's irregular. When we go to 1, you can see pleura over here. Can you see that?
Yes.
And then really, can you see the thin pleura there? It's very thin. And you've got this irregular margin over here. So can you see, when I press R2, can you see this image here? That's pleura.
Okay. Okay.
And that's lung that's basically destroyed below it. That is, I agree, static bronchogram that you see. A little bit irritating today. It's not working. But can you see how irregular the margins are? So what do we call that? What is that?
Sign. Fractal sign.
That's fractal sign. That's it. If you have that kind of an appearance in a baby who previously had RDS, what would we be thinking? So if you look at the left side, do you have any evidence of shred sign or a fractal sign?
No.
And on the right side, you've got some evidence. So let's look at the other regions.
Okay. Okay. Here on R3 also we have static bronchogram and with no pleura here, no? At the R3.
So again, you've got here I would worry that you have subpleural consolidations with atelectasis because you don't have pleura. Can you see? No pleura.
Yes, no pleura.
Now, do you realize the difference between the two?
Yeah.
So there's pleura there with basically regular margins below that. So that's a shred and a fractal sign. Again, pleura visible here, probably disappearing. But can you see any pleura here?
No.
Okay. So this is subpleural consolidation with atelectasis. Now, these areas here, they're static air bronchograms. Can you see? They're not moving in and out. They stay there because air cannot move in and out. So that's because there's atelectasis. They're at the margin of atelectasis. So air is reached here. You've got lung that's fallen away. What about here?
Here, I think the pleura, we can see the pleura.
So can't see it over here, but definitely over here.
Yeah.
Definitely over here. So, I mean, these are large areas of shred sign. But here, basically, you've got lung that's completely destroyed with a large consolidation falling away from the pleura. So if you were thinking of a diagnosis here, what would you be thinking of?
It could be pneumonia, this one.
Absolutely. It's pneumonia. So really, the reason I'm thinking pneumonia at this particular point is it's focal. It's on one side. I've got shred sign. clearly from my perspective, this is probably the reason for deterioration. And I mean, oscillating this baby and putting the map up basically allowed better recruitment to allow us to saturate this baby. But the baby remained in a significant amount of oxygen for a significant period of time. So again, I'm just coming back to the fact, mental modeling is very important in this situation. But really, we grew Klebsiella from the ET secretions and our CRP went up. So it was quite an interesting kind of a presentation. This is the lower part of the lung field. Whether there's a small element of fluid there, it's debatable. Might just be that that's the diaphragm coming in. But I mean, if you look at the images, it's a classical shred sign for you. Any confusion about the shred sign and the fractal sign?
Yes. Hi.
Yeah.
So in the R3 and R4 images, if we can't see any pleural line, is this isn't the shred sign?
So what I'd say is this could be a large area of mixture of atelectasis and shred sign. It's very large if it is, because the lung is, that's a significant proportion of the lung that's destroyed. Basically, the shred sign is described. Can you see my marker?
Yes, I can see it.
That is a classical shred sign for you. I'd say you mix more atelectasis. You've lost lung from the margin. Subpleural static air bronchograms consolidation. Again, here the margins, they're not as irregular. You don't have that cavitation. You have a little bit of dropout from the rib over here. So that's acoustic shadow for you. So for me, this is consolidation. Again, is consolidation. Here it is atelectasis consolidation. Some people might say that, that's a very large shred sign. For me, the margins aren't irregular enough. I think that's more of an atelectasis with the consolidation.
Okay, thank you.
But for me to say that this baby's got pneumonia, no doubt about it.
Can we use Doppler to differentiate between the two?
Absolutely. That's what I was going to say. That really what you need to do is you need to put Doppler. And if you have clear blood vessels, and I haven't done that over here, I completely agree. You have blood vessels over here. That really tells you that you've got the console or Doppler, in this particular region, or kind of that would tell you this is more atelectasis. My advice to you is don't get too hung up on it, guys. I want you to treat lung ultrasound as what you can see barn door. What I cannot see here is dynamic air bronchograms anywhere. And really, it's really important that you guys know the difference between static and dynamic air bronchograms. That's really crucial. So we might just maybe during the revision phase, when we're doing consolidation, is cover that again. I've got a library of about 500 to 1,000 images, maybe trying to try and see whether we've got better images of dynamic versus static bronchograms. But can you see how they don't disappear here? The reason they don't disappear at this particular point is because you've got air that's trapped within them. There are no fluid bronchograms. They're bright, they're not dark. And they definitely don't go in like a snake.
Just one question about R3. Did you see the pleura on R3?
So I can't see it over here. The question is it here? I can't see it. It's just broken. Okay. So it's irregular there, but I can't see it over here. Okay. That's why I think there's an area of atelectasis. R4, I can definitely see it here. I can see it. It's very irregular. Here, whether you can see a thin margin, I cannot see it over here at all. Again, is my probe perpendicular? Is that an issue? Do I need to move my probe up to get a slightly better view? So what I've done over here is I've actually zoomed in a little bit. Maybe zooming out might have given you a better image. So play with your probes. But in terms of sepsis, I think nobody will doubt this is most likely pneumonia. Put vessels, you're really thinking pneumonia at this particular point. It's focal as well, as opposed to being in both lungs. So again, if you have a situation where you've got changes like this, chronic lung disease can also present like this. But really, the changes would be diffuse, symmetrical more. Or sometimes the right lung might be more damaged than the left. This is quite an insidious presentation. So you clinically correlate. You start antibiotics, you watch your CRP comes back elevated. That's why we're thinking this is kind of infected. Klebsiella. So last case. This is a very nice case. So, Kenaz, do you want to have a go at this? Maybe with Sujit?
Yeah, sure. Can you hear me, Alok?
I can hear you, Sujit. Kenaz, are you? Kenaz might not be able to respond.
I'm happy to go ahead, Alok.
Go for it, Sujit. So 34 weeks, this is not an intubated, ventilated baby. So this baby was
sorry,
on the...
I can mute now finally. The thing had frozen.
That's great. That's great. So we have Kenaz as well. So this is basically a decent sized 34 weeker. This baby was about 2.8 kilograms. So kind of a decision was made once the baby was born, because the baby didn't have signs of respiratory distress at birth, did not need resuscitation. It was a spontaneous onset of preterm labor with no other risk factors. Membranes were intact with a single risk factor. The baby was kind of managed, discharged to the mother on the postnatal ward, but an agreement in principle that for babies like this, we normally review babies like this at a few hours to make sure things are going well. We do sugars, and I think there were midwifery concerns about a low blood sugar. The baby was reviewed by an SPR, and I think the overall feeling is you look a little bit cyanosed. Is he a little bit kind of not entirely right? Took the SATS probe, put the SATS probe, preductal saturations were about 88%. No signs of actually severe respiratory distress, no grunting. The baby seemed comfortable, alert. But I think overall the feeling was, because of the hypoxia, we're kind of in a situation where at 2 hours of age, the baby's admitted to the neonatal unit, started on 6 liters of Optiflow, and has this gas. The baby's FiO2 gradually builds up, and about kind of 3 hours of age, we have SATs of 88 to 92. The baby also had a chest X-ray, but I'm not going to tell you what the chest X-ray showed. So we'll show you what the lung ultrasound shows. Any questions?
What age was the lung ultrasound done, Alok?
So about 4 hours.
4 hours, and I take it from a cardiovascular point of view, no murmurs, femorals, palpable.
Absolutely.
Okay.
Absolutely right. Yeah. So I'll give you some more information that I did at this time, but let's have a look at the lung ultrasound. So R1, R2, yeah.
Yeah, so R1, so I can see multiple ribs, multiple rib spaces. The pleura, the pleural line appears thin. It's regular.
Yeah.
I can see comet tails. Right to the left of the screen is this tissue-like thing, which I think is probably the thymus.
You're absolutely right. Yes, absolutely right. Yeah.
So I can see clear A lines. There is pleural sliding, and there are few comet tails that I can see.
Sure.
And this is on the right side. I can see what looks like a pulsating tissue. I think is that the heart?
The right side. So
here, this
liver.
No, I'm still on the left screen, Alok.
Yeah. Sorry.
Just below the thymus.
Yeah, you're right. That's heart.
Yeah,
that's heart.
Yeah.
Heart pulse coming through. Yep, you're absolutely right. Yeah.
And then on the right screen, so this is R2. Yeah. So I'm seeing again. I'm seeing, so right on the left-hand side, I'm again seeing a tissue-like thing, which with no pleural line. I suspect that's probably the thymus, with thin, clear pleural lines, with some comet tails. There is clearly pleural sliding, good A lines, well-aerated lung fields. And towards the right-hand side, I'm seeing tissue-like, which I suspect, given that this is R2, it is the liver.
Yeah. So what's the difference between the image on the right and the image on the left?
So I would, on the right hand side, I wouldn't have expected to see this thymus like shadow. That is the thymus. And then there is
so I don't have very there
is this Yeah, the shadow underneath that I'm seeing, so below at around about 2 to 3 centimeters, which
That's
looks
hard. That's
so
hard.
that's the heart
There's
there.
nothing to worry about with that. So this is image optimization. So what I'm doing is I basically lose my deeper tissue at 3 centimeters. And the reason for that is I'm using a frequency of about 11 here with the linear probe. So what I've done is I've moved down, I've basically dropped my frequency, and I'm using sharp modes to image optimize. And really what I'm getting is a decent A-line profile with some comet tails, but A-lines that are visible all the way through. And this is virtually the whole of, R1 and R2. So in terms of kind of, if you really want to improve, like if you've got your depth sorted and you want to improve your image for the depth, especially in the GE, you can drop your frequency a little bit to kind of image optimize, which gives you the profile right through to the distal tissue, which kind of is a little bit better defined. So you can see A-lines all the way through to the deeper part of the image, which you can't see in this profile. I've also just zoomed out a little bit. So I'm just image optimizing here.
Okay.
Yeah. What do you think about, do you think normal, abnormal? Any?
No, so to me, this looks like normal,
Sure.
normal well aerated lungs.
Lovely. So again, this is just another example of the right side. So so in the previous image, if I take you back at this particular point, I just wanted to show you the difference between use of sharp mode. So I basically at this particular point, using a very high sharp mode, which is making my image look blurred on the right side. Actually, you can alter CDI and this image is basically, in terms of quality for the superficial areas, this image is the best. But if I want to look at the deeper A-lines, I can drop my frequency a bit and I can see A-lines all the way through with comet tails at the top. So sometimes just playing around a little bit at this particular point is really helpful in you being able to make a diagnosis. But let's carry on. So this is the left side.
So on the left side, so again, multiple rib spaces, there is good, nice thin pleural line seen, which is sliding with a few comet tails, A lines seen throughout. I can see B lines towards the right of the screen with a double lung point.
Very good. Beautiful. Absolutely beautiful. And again, what I've done is I've just dropped my frequency a bit to get a little bit more depth. And it just means that I can see a slightly better lung point. So over here.
Yeah.
But A-lines visible all the way through. Comet tails, really good sliding. That's visible all the way through with the comet tails. You can see it really nicely. So any worries about that for a 4-hour-old baby? You happy?
Yes, I'm very happy. Yeah.
Okay. So let's just say that R1, R3, R4 and L3, L4 had exactly the same appearances. And this is just, again, I've dropped the frequency to 8 over here because I want to get depth all the way through on the left side. So L2. Happy with this?
Yes. Yeah. So I'm happy there is pleural sliding and it looks like a sandy beach sign, seashore sign.
Yeah, perfect. Okay. Visible everywhere. So what's your diagnosis?
So transient tachypnea is a possibility.
Yep. But you're absolutely right. It's just a lot of oxygen to be in and still not saturating.
So respiratory distress is another possibility.
No respiratory distress at all. There are no signs. This baby is not recessing, not grunting.
And these saturations, are they preductal or are they postductal?
So these are preductal saturations. So I put this baby in 100%.
Was there an improvement?
No, I could not saturate this baby.
So that's a hyperoxia test failing. So you need to look at the heart and think of cardiac.
Absolutely. So just it goes back to that first point that I made right at the start, that if you look at a lung ultrasound and it's band or normal in situations like this, then you need to think of alternative causes other than respiratory. And really, if the ET is secure, it's not low, your lungs are normal, think about potential other causes. I mean, this baby we eventually diagnosed with supracardiac DAPVC. And used very well to demonstrate normal lung. And this is very nice transitioning normal lung with you with a little image optimization to try and make sure that I can see the deeper areas, make sure there are no deep consolidations. So any questions? I think in summary, what I'd say, what is very important is that for this aspect, if you're desaturating on the ventilator, go back to basics. DOPE is a mandatory test. Clinical diagnosis first, transluminate, check your ET position, make sure your tube's not low, for babies over 1 kilo, weight +6, that it might be something as small as that clinically that actually helps you with your diagnosis. But if you then think that there's a possible respiratory cause for this deterioration, depending on the clinical presentation, background, age of presentation, then pneumothorax pneumonia, BPD atelectasis, and PDA, as Dr. Almedina has shown us, a diagnosis that can actually be made by lung ultrasound with clinical correlation. I think the important thing is once you've made a management decision, what you really want to demonstrate is that this baby is getting better with your management. Now, that might be insidiously getting better if you are needing to treat sepsis or pneumonia, but something like a kind of a collapse consolidation with a tube down the right main bronchus, you pull the tube back, and clinically the baby should improve over a period of time with recruitment maneuvers. So, it's important from our perspective to keep an open mind. If your lung is completely normal, then really, absolutely no doubt, think about other causes. If your heart then is completely normal, then you might have to think about causes outside of that. We've had a TPN extravasation in a UVC for a baby that we were managing, who basically had significant rise in oxygen requirements, and the abdomen was basically rock hard. We were losing our FRC, that might be the cause. So that, in summary, is how you use lung ultrasound. We've covered 3 protocols now. We've covered early respiratory distress soon after birth. We've covered late respiratory distress, and we've covered acute desaturation on the ventilator. On the coming Friday, Dr. Nadia Yusuf will be talking about heart-lung interaction, and then I will be talking about use of lung ultrasound for the purposes of lung recruitment on Sunday. Any questions very quickly?
I'm sorry, Alok.
Yeah.
I had a break in my net. I didn't understood what are the next sessions.
The next sessions are heart-lung interaction by Nadia on Friday. And then I'll be talking about use of lung ultrasound for lung recruitment on the ventilator of CPAP. Yep. Okay. On Sunday.
Sunday or Saturday? Because in the program is the 1st of April.
Is it the 1st of April?
It's Saturday.
Okay, it's Saturday then. It's Saturday.
Okay.
Yep. Yeah. Somebody else had a question?
Yes, please. The bronchogram, static bronchogram, can they be seen in atelectasis, or you don't see bronchograms at all?
You can. So
it's only the dynamic you don't see, right?
So what I'd said is when you have atelectasis can be microatelectasis. This is where we need to differentiate what is a large area of atelectasis. Now, if you have a large area of atelectasis, you might still have air coming into the proximal parts of the lung. Now, if you have air coming into the proximal parts of the lung, you might remember in my lecture I said at the margin, you might have static air bronchograms followed by distal atelectasis. So I think it's really important, guys. Anybody who's missed that lecture, it is visible. Go through it again. But maybe next time before I start the talk on lung recruitment, I will show you lots of images of static versus dynamic air bronchograms. In lung ultrasound, the caveat is the same as it is in cranial ultrasound. Try not to overinterpret. Try to keep it simple. Try to pattern recognize. Don't get too confused. Overall, differentiating atelectasis from collapse consolidation, really, There is an element of both when you have a large collapse consolidation, microatelectasis, where you have atelectasis from the pleural margin that you see in an alveologram with RDS. It's got a completely different pathophysiology. You've basically got surfactant deactivation with hyaline membrane disease there. So try not to confuse those things. But more importantly, what I'd say from your perspective is look at the entire lung field, clinically correlate, and more or less you will always come to the mental model of what your likely diagnosis is going to be. This is very important because when you do your testing and you give the exam, there will be lots of images for you to interpret in relation to clinical history. Remember, when you give your exam, there's no time limit for how long you take to answer the 50 questions. You can sit there for the whole day and do it, but there will be a lot of pattern recognition that you will need to do. So, I mean, I'd say keep it simple. Use the pattern recognition as it should be barn door shred sign. But even if it's not barn door shred sign and there is an element of atelectasis there because you can't see the pleural margin, actually, clinically, if you correlate and you look at that, a focal area, that kind of clinical presentation, I would be really worried about infection if I had that kind of presentation. It's not subalveolar, subpleural atelectasis along the whole margin of the lung that you see in snowflake sign. It's a very focal area that you see. So, you know, keep it simple. Any other questions? Lovely. I'm really grateful, guys. More to come. And really what I'd say is once we finish on the 15th, after that, I would really be guided by you as to how much handholding you want, how much practice you want, how frequently you want to have the peer review sessions. But for those people who want to do it, I will be using the structured assessment form for you. It'll be less of kind of me talking, more of you talking and peer review. And really what we do is at the end of it, we try and score ourselves. God bless you all. Thank you very much.